So hemolysis. What I'd like to start with is that you have red blood cells, and your red blood cells go around and deliver oxygen to your body. Those red blood cells have a lifespan of about 3 months, 120 days. Once they get in towards their end of their life, they are going to die at some point because they pick up oxidative damage to their membranes. Their membrane becomes less flexible. As it becomes less flexible, it can't squeeze down capillaries as well as it did before. And in the same way as skin gets older and you get physically less flexible as you get older, the same is true of red blood cells as well. Now, within a red blood cell, there are some enzymes that help protect. It's kind of like natural antioxidants within the cytoplasm of those red blood cells. And so the red blood cell can resist a certain amount of aging, but at the end of the day, everything only lasts for a certain amount of time, and after 120 days, they do die. If you've got sickle cell, and the membrane of your cell and the hemoglobin molecule in itself changes shape and damages that membrane, actually with sickle cell, your red blood cells may only last 7 to 9 days. So you are having to replace, if you've got sickle cell disease, 10% of your entire red blood cell per day. If you have red blood cells that live 120 days, let's just round that off to 100 to make the maths easier for you. That's about 1% of your blood volume per day. Your body is constantly sensing and saying, do you have enough circulating red blood cells there? And if you don't, your bone marrow will step up and make more red blood cells. So if I was bitten by that saber-toothed tiger yesterday and I bled out half a litre or a litre, my body would sense that I've lost that half a litre and it will go into that process of trying to replace that. So to begin with, what it will do is it will say, well, imagine that you've got a training camp in your bone marrow, and you've got right from the very beginning, baby red blood cells, you've got adolescent red blood cells, you've got red blood cells of fighting age, and then you've got fully trained red blood cells ready to kill. You know, that's your military training of your red blood cells. When you have normal day-to-day losses of red blood cells, what you do is the people who are ready, you know, they've got all of their kit on, they're holding their rifle, they're all just shooed off into action, ready to go. And those are svelte, biconcave red blood cells with all of the old nuclear material taken out, and they look like perfect red blood cells. They're ready for duty. Now, if I cut myself and I lose a lot of blood volume, my bone marrow is going to push out red blood cells that are ready for duty. But depending upon how much I have lost, it may also start sending out those people who are halfway through training. And if things are catastrophic, my leg's been chopped off, I'm hosing everywhere, I've lost 80% of my blood volume, my bone marrow will get into a state of desperation and just start throwing out, you know, adolescent red blood cells. You know, got blood cells that are willing to, you go send those out as well. You start throwing frying pans, anything that you can get in your bone marrow, you start throwing out. And your bone marrow will empty out in desperation in the hope that there's something in the bone marrow that will be useful when it's in the circulation. So that is, if I cut myself, if I have a massive upper GI bleed, if I chop my leg off, I go through a graded process of saying, the first thing I'm going to send out is some reticulocytes. The next thing I'm going to send out is normoblasts. The next thing I'm going to send out are blasts from my bone marrow. I'm just going to send more and more immature cells. The same is true with white blood cells. I'm sure you've seen left shift, haven't you? Left shift gives you a bit of an idea of the white cells, how young those white cells are that we're pushing out. And we do the same things with white cells. You've got good neutrophils, then you've got promyelocytes, metamyelocytes, and further immature white blood cells being pushed off into the circulation. When we see immature red and white blood cells in the circulation, that is called a leukoerythroblastic blood picture. Leuco, white, erythro, red, blastic, babies. Baby red and white blood cells in the circulation. And what leukoerythroblastic blood picture is how desperate is your bone marrow, pretty desperate, to the situation that your body finds itself in. So where do I see? If I look on and I see normoblasts, reticulocytes, normoblasts, promyelocytes, metamyelocytes, myelocytes, on it, that equals leukoerythroblastic blood film. I then say, what are the list of things that give me a leukoerythroblastic blood film? Chopping off my leg would give me a leukoerythroblastic blood film. A massive road traffic accident would do that. Severe sepsis, where I've got septic shock. My bone marrow is going to go, you look like you're going to die, let's just throw whatever we have to at it. So acute severe illness is all you need to remember. And I'm not going to write down what all of those acute severe illnesses. You're doctors, you've been there, you've seen what it looks like. When you look at somebody and they're all mottled, don't be surprised if they have a leukoerythroblastic blood film. Illness and trauma. The next thing that gives you a leukoerythroblastic blood film is, imagine your bone marrow is like a toothpaste tube. If I start rolling up the end of the toothpaste tube, the toothpaste has got nowhere to go, and that toothpaste starts getting squeezed out. And your bone marrow is much the same. We start filling up your bone marrow with metastases. So if you're a woman, most likely breast cancer. If you're a man, most likely prostate cancer. But it could be lung cancer, it could be hematological malignancies, myeloma. If you're a child, you could have glycogen from glycogen storage disorders filling up your bone marrow. But something filling up your bone marrow could squeeze your bone marrow into your circulation. So if you see leukoerythroblastic blood film, all you need to do is walk to the end of the bed, and if they're sitting there reading the newspaper, they've got widespread metastatic cancer to their bone. If you look at them and you think, I don't know whether to call the crash team or not, then they have an acute severe illness, and you just need to do your doctory magic to work out what their acute severe illness is. Just seeing whether I put that on here. No, I don't think I have. So that is normoblasts. Normoblasts are red blood cells that still have their nuclear remnants in them. They still have their nucleus in. That's slightly different to Hal Jolly bodies, where the nucleus is all shriveled up, but they haven't had those taken out. And those are a sign of hyposplenism, of not having a spleen to take out the nuclear remnants. These are nucleuses. Myelocytes, promyelocytes, metamyelocytes. And that is increasingly severe. Go back to this healthy person. Healthy person, your blood cells are going around. After 120 days, they start to feel a little bit old and sick, and eventually they keel over, and their membrane breaks open and releases hemoglobin into the circulation. Now, hemoglobin, as a molecule, is toxic to your nephron. So that hemoglobin molecule could get washed through, make it through the glomerulus, and poison the nephron, damaging your kidney substance over the years. And as you would get older and older and older, you would kill more of your nephrons and eventually end up with renal failure, because hemoglobin is toxic, which is why when you have rhabdomyolysis and myoglobin, which is also toxic to the nephron, it can cause catastrophic acute kidney injuries. We don't want that to happen. We don't want free hemoglobin just meandering around the circulation. So how do we stop that from happening? Well, Imagine that when our robot overlords come to rule us, and they're going to say, well, some of these people, we can use some of these people for labor. They can do the jobs that we don't want AI to do. And some people are too old, so we will get rid of those people. How would an alien decide? Because kind of we all look the same. It's like dogs. Old dogs, young dogs, they all look the same. So how would they work out which ones you want to keep, which ones are young and fit that you're going to get some work out? And you could play the world's cruelest game of limbo. You know, that game that you play on, you put a little bar across, you play some Jamaican music, and then you try and make it underneath. Everybody who makes it underneath gets to live. Anybody who gets stuck as they go under, they're chucked over the side of the boat or they're dealt with. You lower it a little bit further, then everybody tries to go again, and the spleen does exactly the same game with red blood cells. So you have a tiny capillary, this is a red blood cell, and the red blood cell's got to squeeze through the cord of Bullroth, it's called. And then he pops out the other side, and he's managed to make it through the hideously cruel game of limbo. And waiting on the side are macrophages waiting to eat any red blood cell that can't make it through the cord of Bullroth. So red blood cells, as they get older and they pick up oxidative damage to their membrane, become less flexible. They can't fit through that tiny little cord anymore, and they get eaten by a macrophage. So their hemoglobin doesn't contaminate blood plasma and end up damaging your nephrons. Does that make sense? And that's the way that your body wants to get rid of red blood cells that are old and sick. And that's called extravascular hemolysis. Outside of the circulation, outside of the vasculature. So extravascular. It's a really good way of getting rid of your red blood cells. Now, I don't know, when you look at somebody, you can tell when they're a smoker, can't you? Because their skin looks grey and they look a little bit old and haggard. They get age before their time. When somebody's got cancer, often when they come into and they haven't got a diagnosis of cancer, you look at them and just think there's something wrong with that person. And so even if there's something wrong with somebody inside, it often shows on the outside of their body. And in the same type of way, if a malaria parasite, low-grade malaria, not falciparum, low-grade malaria parasite, gets inside, he's munching away inside, and that red blood cell, as he's going around, is feeling sicker and sicker and sicker, picking up oxidative damage. And eventually, even though the parasite is inside the red blood cell, the membrane becomes less flexible, gets stuck, the macrophage comes in and eats that red blood cell with the malaria parasite inside. So even intracellular parasites are picked out through this process. So it's a very, very effective process, and that is extravascular hemolysis. The last thing that we really want to happen is red blood cells fall apart in the circulation. That's not a good thing. We said that there are some enzymes inside your red blood cell, and those enzymes help resist that oxidative damage. What if you're born without those enzymes? What then happens to your red blood cells? They age much faster, don't they? When they're picking up oxidative damage, there's none of that magic sun cream to protect that oxidative damage from occurring. So instead of them lasting 120 days, maybe they only last 70. And then they'll get stuck because they've aged before their time in here. Now those enzymes are G6PD, pyruvate kinase. I'm going to make a list of these. I'm going to show you where they are. You don't need to make a note of them. I just want you to understand the principles. So if you have G6PD deficiency or pyruvate kinase deficiency, you are going to be undergoing a much higher rate of extravascular hemolysis than you or I. So what do I mean by that? Well, if you imagine my red blood cells last 120 days. Let's make it easier for the mass, 100 days. So I have to replace 1% of my red blood cells every day. If I've got G6PD, or pyruvate kinase deficiency, my red blood cells might only last 50 days, just to make the maths easier. I now have to replace 2% of my red blood cells every day. So I am undergoing twice the rate of extravascular hemolysis as I would do if I didn't have G6PD. The second thing that I can happen is I can take drugs that accelerate the rate of oxidative damage. I think about them as drugs that are abrasive, like sand, rubbing away on the surface of the red blood cell. That will also age my red blood cells faster if I'm rubbing and damaging the membrane. If I'm taking those drugs, I may also increase my rate of extravascular hemolysis. The worst combination is if I had G6PD deficiency or pyruvate kinase deficiency, so I couldn't protect myself from oxidative damage, and then I took one of those drugs. Then I would undergo a massively accelerated rate of extravascular hemolysis. So those sandy drugs that are abrasive and damage the surface. Sulfonamides. Antimalarials. Nitros, anything with nitros in it, nitrofurantoin, a whole load of other nitros, and dapsone. So those are oxidatively damaging drugs. There are others, but those are the ones that tend to come up in the exam. And the sand part is to imagine the abrasive damaging process to the surface of the red blood cell. What do you think would happen to a sickle cell that tries to make it through that cord of Bullruth? It's going to really struggle, isn't it? So you've got the sickle cell comes up, he's an abnormal shape, he sticks in that little cord of Bullruth, a macrophage comes along and eats it. What makes a cell sickle? Oxidative stress makes a cell sickle. So actually, the point of sickle cell is that it gives you an evolutionary advantage for malaria. Because what happens is a malaria parasite, you've got a red blood cell, he's okay, he's kind of in his normal shape. A malaria parasite manages to sneak into it. And the red blood cell is, what's going on here? Oxidative damage. As soon as it notices that oxidative damage, then he sticks in the spleen eats him up. So instantaneously, as soon as there's the slightest bit of oxidative damage by a malaria parasite, it's going to end up sticking in the spleen and be taken out of that. Although that was the design for sickle cell, if you give oxidative damage from any one of a number of reasons, then those cells might all decide to sickle at the same time, and then you end up with a crisis. And in the spleen, if you've got all of these red blood cells that have sickled, they're going to block the spleen, causing infarction of the spleen. You may also get your entire blood volume all stuck, like an entrance at a stadium. They've got a tiny little bit to get past. They've all changed shape. They're all enormous. It's like massive, morbidly obese people trying to make it through one doorway all at the same time, and they all get stuck. And you get log jamming of your spleen, infarction of your spleen, and your red blood cell count drops and drops and drops. So let's go through all of our causes of extravascular hemolysis. I've told you most of them already, but we're just going to organize them so that you can remember them. The easiest way I think about it is anything wrong with the red blood cell itself. If I've got something wrong with the red blood cell membrane, the enzymes in it, or the hemoglobin molecule itself, that red blood cell is going to find it difficult to get through. So what are the problems with the membrane? There are 2 inherited disorders of the membrane: inherited spherocytosis and inherited elliptocytosis. Elliptocytosis. And those are cells that don't have a biconcave shape and are just like balls. Those are spherocytes. And elliptocytes are red blood cells that look like rugby balls. Those aren't going to make it through the cord of Bullruth very well. There are degrees of severity when you inherit these. Some people just lose, you're losing 3 times as many red blood cells, but your bone marrow can keep up. Some people are affected so severely they need transfusions almost weekly. If you end up transfusion dependent with one of these, what would be the solution?
Bone marrow transplant?
So bone marrow transplant would make that better. If I do a bone marrow transplant, I've got the risk of graft versus host disease. I've got the risk of all of the immunosuppression that goes along with that. And that, although would cure the disease definitively, I could die while I have it, and there are lots of other things going on. What could I do? I can take the spleen out. So can people live without the spleen? There's loads of people who don't have a spleen. Yes, I would prefer to live with a spleen. It does some really important work. If I pick up a low-grade malaria, it's going to sort me out. There's other immune functions that it does, but kind of like your appendix does do some stuff. Your gallbladder does do some stuff. You are better with it. But if I had to choose between bone marrow transplant, which would be definitively curative, and all of the complications that go along with it, versus be without a spleen, I'll go without the spleen. Even though that isn't a cure, it just deals with most of the problems in a way where, okay, I've got a good enough result without all of the catastrophic consequences. So yes, I just take the spleen out with these. We've already said, not the membrane, but if there's a problem with the enzymes inside, let's call that enzymes. Let's do that. Pyruvate kinase and G6PD. Deficiencies, those are deficiencies of each of those. That means that you're much more prone to oxidative damage and not being able to protect yourself for those. Problems, I'm now going from membrane into the enzyme into the hemoglobin molecule, and that's just sickle cell. We've also talked about oxidative drugs, sandy drugs, and you definitely don't want to combine these two things together, the oxidative drugs. And we've already mentioned low-grade malaria. The last one, the last cause, so that's all of the causes and we've talked about them, is autoimmune hemolysis. So when we come back to extravascular causes, there's some caveats in these, but essentially, autoimmune hemolysis is extravascular and it's broken off into 2 types, warm and cold. Warm are caused by drugs. Cold is caused by everything else. There's lots of different infections cause those. Essentially, you get an immunoglobulin grabs hold of a red blood cell with one hand, grabs hold of another red blood cell with another hand, and now you've got this matted red blood cell making it through to the spleen, then gets stuck in the spleen, then the macrophage comes in and eats it. So autoimmune hemolysis, low-grade malaria, membrane enzymes, and sickle cell disease, as well as drugs that cause oxidative damage. Do you understand that so far? The only other time that you see spherocytes, either somebody has hereditary spherocytosis, or if you get a bit of an immature red blood cell, it hasn't got its kind of svelte shape yet. So you have reticulocytes, spherocytes, normoblasts. And all of those are immature red blood cells. So if you get spherocytes just because you have slightly immature red blood cells, that's not the same as all of your red blood cells being spherocytes because you've got hereditary spherocytosis. Does that make sense? If I bleed, if I just cut myself and bleed and I lose blood because I'm bleeding, and you were to do a full blood count and a blood film, what would you see? Well, what you would see, if I just lose blood, I tend to have, obviously, an anemia if I lose enough blood. I can get some reticulocytes, can't I? If things are really bad, I can end up with some normoblasts. That's what I think. What else do you tend to see if you lose blood? Your white cell count can go up a little bit. If you lose a catastrophic amount of blood, you can get a leukoerythroblastic blood film. Depending upon the trigger, your platelet count can also go up as well. Depending on. But overall, if you lose blood, you just get an anemia and a reticulocyte count. What about if you lose blood? Just going to make that smaller to make my chart easier to write. What if you lose blood, but it's actually caused by extravascular? I get all of these things, depending upon how severe that extravascular hemolysis is. I'm turning over and breaking open cells. So every time I break and open cells, my LDH goes up. I'm turning over a lot of hemoglobin molecules because the hemoglobin molecule comes in, I've eaten it up my macrophage recycles that throughout the reticular endothelial system. I want to reuse that hemoglobin. I reuse it by putting it through the heme cycle, and so my bilirubin goes up. And not that anybody measures unconjugated and conjugated, but that is unconjugated. So I do get a raised LDH and a raised bilirubin, as well as all of these things. So if I get this, then I'm looking for this as well. Moving on now. What happens if a red blood cell pops open in the circulation and releases its hemoglobin? We said that that hemoglobin molecule will get washed through, could make it through the glomerular basement membrane, and poison the nephron. It would be very imprudent if your body had never evolved anything in order to be able to deal with the consequences of that. So, as that red blood cell breaks open, if it did die in the circulation, the hemoglobin molecule comes out, and what your body has is a special protein around to specifically bind and mop that up. And once a protein binds to that hemoglobin molecule, now that's too big to be able to fit through the glomerulus, and so you are now protected from that hemoglobin molecule. And that protein is haptoglobin. Our tests, we can measure the amount of free haptoglobin there is, but we can't measure the amount of bound haptoglobin. So let's say I'm breaking open lots of red blood cells, hemoglobin is coming out, it's binding to free haptoglobin, making bound haptoglobin, and I ask the lab, I'm having a lot of intravascular hemolysis, I'm binding my free hemoglobin, what will my haptoglobin level be if I've got lots of? It will be low. So my free haptoglobin level goes down when I am breaking open red blood cells in the circulation. That's called intravascular hemolysis. So we've talked about extravascular. We're now parking that. We're now talking about bad intravascular hemolysis, and your body has evolved haptoglobin. We can measure it so that if somebody does have bad intravascular hemolysis, we can see that by the fact that their free haptoglobin level goes down. Eventually, you will run out of haptoglobin, and haptoglobin can no longer do the job of protecting you. So is the hemoglobin molecule going to end up making it into your nephron? No. You've got a backup, the jack of all trades and master of none, albumin. Albumin will kind of do the job if it's around. It will attach to hemoglobin and make a substance called met-heme albumin. When it's put together, it looks like meth-heme albumin, but it's met-heme. I have changed hemoglobin to stick to albumin. That's what the name comes from. The jack of all trades and master of none, I keep on reminding people because it's as a generalist, primarily in my work, people use it as if it's an insult, being a jack of all trades, being a generalist. I keep on reminding them that they're not saying the end part of the saying. I don't know whether you guys know the end part, but the whole saying is a jack of all trades and master of none is more often useful than a master of one. So that's the whole saying, and people kind of picked off just one part of it. So if you do become a generalist, always keep that in the back of your mind. Once albumin is all bound to hemoglobin, at that stage, free hemoglobin can now make it out into the urine. And I can see a dark Coca-Cola colored urine. And that Coca-Cola urine is an indication that there's hemoglobin in there from some cause. So free urinary heme. I've told you that hemoglobin is toxic to the nephron, so about 7 days after hemoglobin starts to make it into the urine, a whole load of cells that are from the tubules start to die off and be shed into the urine, and that's called urinary hemosiderin. And that's at 7 days. So if I find low haptoglobin and no urinary hemosiderin, I know that that hemolysis has been going on for less than 7 days. If I find both of them, then it's been going on for longer than 7 days, but I don't really know how long. We don't do tests for this anymore. They used to be called the Schum's test, but they don't do it. You do need to know the pathophysiology. Because this is pretty good, we aim at doing this, and we also look for this as part of your examination. You can, when you ask for MCNS of the urine, you'll also be told whether this is present.
Sorry, what's that word again? Urinary?
Hemosiderin, which is my writing is so terrible to cover up for my bad spelling. Hemosiderin. Pardon? Is raised, because that is hemosiderin. You'll see it in a few cases. You see hemosiderin is the iron pigmentation when it gets into cells. So you also see hemosiderin staining in legs. So if people have got venous insufficiency, or they've had cellulitis in the past, you know, you get cellulitis and then some people tend to get almost looks like blood staining in their legs. That blood staining goes away, the redness of it, but they're left with this brown patchiness in their skin. Or if they've got venous insufficiency, it just slowly accumulates. That is hemosiderin causing lipodermatosclerosis, the thickening and the pigmentation of the skin. If you were unlucky and you were left with that, IPL and laser does very good to remove it, in the same way as laser is pretty good for stretch marks. So people get stretch marks that once they've gone through the active stage into the passive stage. it can be very visually effective at changing how it works, how it looks.
Sorry, can I just check?
Yeah.
Because the iron's lost in the urine,
Yep.
you're not at risk of iron overload in these cases.
So
You're losing the iron.
if I'm losing in this, so we're talking about bad intravascular hemolysis. My red blood cells have broken open. I am now peeing out the hemoglobin, losing the iron. I will become iron deficient in the same way as I would if I had an ulcer and I was slowly leaking out into my poo. The difference being is I've got an ulcer, the blood itself doesn't damage me on the way out, but if I've got intravascular bad hemolysis, it's damaging my kidneys on the way out. That makes sense? If I am desperate, so there are certain situations where, let's go back to extravascular. Let's say I've got inherited spherocytosis, and every day I'm just destroying loads and loads of my red blood cells. I am recycling that iron, and if I am now transfusing weekly over and over again, whilst I'm recycling my own iron, I will become overloaded. Does that answer your question? Okay. Yeah.
Yearly heme, that shows up in the blood. Does that show up after 7 days? Or is that
So you find it in the urinary hemosiderin. You only see. So what happens is the urinary hemoglobin you see today when you have massive intravascular hemolysis. I see that today because some of those hemoglobin molecules just make it all the way through into the urine. On the way, those hemoglobin molecules, some of them poke into the tubular cells. And those tubular cells take about 7 days to die. So you get first, haptoglobin goes down. Secondarily, the amount of methemalbumin goes up. Then the next thing is urinary hemoglobin, Coca-Cola urine. Then 7-10 days afterwards, we shed those tubular cells and urinary hemosiderin is there, as well as urinary hemoglobin if your primary illness hasn't recovered. And we come back to what those illnesses are. Okay. So what extra things do I get if I've got intravascular? I get all of these. The bilirubinemia isn't quite so bad, but you do get high bilirubin because some of those red blood cells are dying by the time they make it to the spleen. LDH goes up, but in top of that, I now get decreased free haptoglobin. We just call it haptoglobin for the lab, but it's free haptoglobin. Decreased free haptoglobin, cola urine, and urinary hemosiderin. So when you see somebody with anemia, you are doing an assessment, like an algorithm of saying, I've got these, but none of these, therefore I must be losing blood out of a hole somewhere. If I've got these and these, but not these, then I've got extravascular hemolysis. If I've got these and these and these, then I've got intravascular hemolysis. And then you can decide on the severity by what you're seeing on the blood film and how bad the anemia is. Any questions? Okay. Your body wants you to undergo good splenic hemolysis, extravascular hemolysis. That's the way it wants to get rid of it. Intravascular hemolysis are caused by violent, unpredictable, unpleasant, and frequently terminal processes. So we're going to go through those. So these are the violent processes, things that cut up your red blood cells, pathologies that cut them up. Pathologies that punch holes in the side of your red blood cells and then all of their guts come out into the circulation. Processes where you squash red blood cells and they just pop like a balloon. And then conditions where there is just an overwhelming, massive attack on your red blood cells that happen all at the same time. So starting with the first one, the first easy one is smashing. So the ones that you see are, if you have your heart valves, when they come and close, they fit very nicely. They've got a nice little soft edge. They brush the red blood cells open when they open and close, out the way when they open and close, and they don't cause a lot of damage to red blood cells. In actual fact, even if you've got a metallic valve, the metallic valve does close and damage a few red blood cells, but not that many of them. As soon as you have a vegetation on there, a vegetation is just like a manky sponge. The valve opens, the sponge sucks up some red blood cells, the valve slams shut, the red blood cells that are caught in that manky sponge all get broken open, and the process does over and over and over again. So metallic valves, a little bit of intravascular bad hemolysis, but metallic valves with vegetations, you can get massive amounts. So metallic, physically, when I started working in Portsmouth, they still did a lot of military drills down there. I saw a few people with renal failure from intravascular hemolysis from doing marches over and over again. So they would do one drill after another drill, and as they were doing it, they would stamp their feet. And the capillaries that were in their feet, every time they stamped their foot, they would break open the red blood cells in the bottom of their feet. And that's called march hemoglobinuria. From marching, I end up with hemoglobinuria. That's descriptive, isn't it? I would have used up all of my haptoglobin on day 1. Day 2 of doing it, I probably would have used up all of my albumin. By day 3, I've saturated all of that, and now I'm moving on to then getting hemoglobinuria, and 7 to 10 days afterwards, I'll end up with some urinary hemosiderin. So does marching for one day give you intravascular hemolysis? Yes, but your body can deal with that. Haptoglobin will do the magic. There's another version when I used to work in Bournemouth many years ago. I lived on a flat on the beach, and every summer there would be people sitting on the beach, very, very stoned, playing bongos all night. And I would sometimes pray for the fact that they would get bongo players hemolysis, and at least their renal failure would send them home, and I could finally get some sleep. So bongo players hemolysis is the same thing, but using your hands on a bongo. So those are smashing open. Cutting. These are processes where a red blood cell is cut open with a piece of wire, like a cheese cutter, like a motorcycle is riding along and there's a wire across the road and the wire just chops them in two. Those are diseases that are called MAHA. It's surprisingly common there, actually, especially in the US, where people ride motorcycles where people don't want them to. So they wind wire around trees, and so it is actually quite common. So much so that you can get helmets with a little blade on the bottom of the helmet if you ride off-road. God agrees. It's a bad thing to do. Don't do it. Okay, so MAHAs are conditions that you get a cheese cutter. What happens is this. MAHA stands for micro, small, angio, blood vessels, pathic, something wrong with those small blood vessels, hemolytic anemia. Microangiopathic hemolytic anemia. So what is wrong with those small blood vessels? You get a small blood vessel, you damage the endothelium, so you strip off a little bit of the endothelium so it's missing. What do you cover? Uncover some tissue factor. Tissue factor triggers factor 7 to 7A. You trigger the final common pathway, you make a clot. Now you've got a clot there, but you shouldn't really have a clot there. So what does your body do? It wants to get rid of that. So you undergo your fibrinolytic pathway. Plasminogen goes to plasmin, which breaks down the fibrin in that clot to fibrin degradation products. But just like a big piece of ice, as it melts, the piece of ice gets thinner and thinner and thinner as it gets broken down, thinner and thinner, thinner and thinner, and eventually, just before it's fully gone, you get left with a little fibrin strand across there. The motorcyclist of your red blood cell goes past, and he's chopped in half. Eventually, that will disappear, that fibrin strand, but there's billions of others happening in other bits of your blood vessels, and those are going to take your helmet cells, this is called a helmet cell, and chop that up each time it goes past another fibrin strand, and those are called fragmented cells. And fragmented cells are also called schistocytes. So as soon as you see on a blood film, schistocyte, you have microangiopathic hemolytic anemia. There is nothing else other than MAHA that gives you schistocytes. Never ignore schistocytes. There is something catastrophically wrong that you need to do something about. And the patients often look very, very well. They won't do in 24 to 48 hours. And you may have a window of opportunity of doing something about this. So what causes MAHA? Well, it's got to be diseases that damage that endothelium. Now, one way you can damage it is much like with turbulent blood flow. If there's a storm, wind is blowing, you have roof tiles, and the wind can be so strong, it pulls those roof tiles off your roof. And in the same way, with very high blood pressure and turbulent blood flow, that can tear endothelium. So in malignant hypertension, also called accelerated phase hypertension, what disease have we got so far that could give you a MAHA? PAN, polyarteritis nodosa. You had a clot, it blocked a blood vessel. Actually, polyarteritis nodosa in itself could leave a fibrin strand. But worse than that, it's going to up your blood pressure again and again and again until your blood pressure becomes so high it tears off that endothelium all over the body. There is another condition in pregnancy. You get preeclampsia, eclampsia, HELP. It's all part of the same spectrum of disease. What does it stand for? H stands for hemolysis from microangiopathic hemolytic anemia. EL, elevated LFTs, because you start to get organ failure from it. LP, low platelets. You get low platelets because they're being used up making up these clots. And HELP is just being caused by spasm of blood vessels, and when you spasm a blood vessel and squeeze it, it's the same as putting your finger over a hose pipe. You get the jet of turbulent blood. And that turbulent blood coming out the other side tears off endothelium. So a couple of people have said that they're going to be late in this morning, which is fine. What I've got to do is put this lecture, this hemolysis lecture, on YouTube so that you can watch the whole thing recorded and you won't have missed anything. So if you are feeling as though you're missing out at the moment, it's fine. I'll put it all on there. The second part of the lecture, if you just try and concentrate and keep with what's happening, I know the trains are really hard, and keep up with what's happening, then it'll make when you watch it next time on YouTube just easier to follow. So this is spasm of blood vessel. This is being caused by globally high blood pressure. TTP and Hus. This disease, for MRCP land, these two diseases are the same. The same inside the body, but when you look and the person looks old and they're confused, we call it TTP. All of the blood picture and everything else we're going to talk about and the things that trigger it and the pathophysiology of it is all the same. But if you have all of the features I'm just about to talk about and the person is old and confused, we call it TTP. If you have all of the features that I'm just about to talk about and the person is young and they have renal failure, then we call it Huss. Now, both of them end up with renal failure and multi-organ failure, and there's not really much of a distinction between the two, and the treatment is the same, and the pathophysiology is the same, so it doesn't really make any difference. No, but for exams, they do like giving you this part with this little bit of history and getting you to pick which one you think it is. So in this condition, you start off with, you get an infection, and that's usually a gastroenteritis caused by E. coli 0157. That E. coli 0157 gives you a bloody diarrhea, but also that toxin is very toxic to the endothelium itself. So that damages endothelium. Endotoxic. Because you damage the endothelium, you expose tissue factor, you get a clot, you break that clot down, just as we talked about, you get a fibrin strand, you chop up red blood cells, badness ensues. Make sense? I could poison everybody in the room here with E. coli 0157. I'm not going to. I know we're giving sandwiches. It's not a trick. I could poison you all. You would all feel awful. Most of you would have some bloody diarrhea, but not very many of you, if any of you, would get TTP or Huss. You have to get this infection and also being born with something wrong with you. And the thing that's wrong with you is you're missing von Willebrand's factor cleaving protein. So what is that? When I make von Willebrand's factor, I make it in a big, gloopy, sticky mess. And that is very, very sticky indeed. What I do now is I chop that up into lots of different pieces, into much smaller pieces, and those smaller pieces are much less sticky. And how I chop that up is with von Willebrand's factor cleaving protein. If you are born without von Willebrand's factor cleaving protein, you now have this infection, you damage your endothelium, but you have such big, sticky von Willebrand's factor that you end up making big, sticky clots that are broken down into these fibrin strands much more widely than you would if you had von Willebrand's factor cleaving protein. So you would get a little bit of intravascular hemolysis if you didn't have this, but you would be fine. You wouldn't end up making it to hospital. You'd just feel awful. So you often see these, there's outbreaks of E. coli 0157, and then you'll have 2 people admitted into hospital, 1 person died. And that's because they're missing this. That could be an evolutionary advantage. Let's say if you were living in a world where you were more likely to get bitten by a tiger than you were picking up food poisoning from a badly washed lettuce, then having stickier blood is more to your benefit than the consequences of getting a clot later when you shouldn't be having one. The mutation that you have, genetic mutation, is Adams, a TS13. Adam, TS13. So that's the mutation that you have that means that you're missing this, that when it's combined with this, you end up with this condition. How do you treat it? Your platelets get very, very, very low, and all of the questions will be aimed at trying to trick you into giving the person platelets. So they'll say, the person has a platelet count of 15, which of these is most appropriate to do? And they'll put platelets on you, and you'll think, yeah, that looks less than 50, that's when I give platelets. You never give these people platelets, because that's just throwing petrol on the fire to make more of these clots and cause more organ damage. In fact, the treatment is aspirin. As soon as the platelet count is greater than 50. The next thing you do, if I'm very desperate, because these people die, 80% of these people die, what treatment do I do to try and get the bad spirits out? Plasma exchange. And actually, these people, we used to treat them with, now it's difficult to get your hands on it, but when we talked about lollipops, we bought a lollipop, my brother sucked all of the juice out, and then I got the icy bit at the end. The cryoprecipitate is all of the big molecules, isn't it? The big juicy molecules that help you clot. Interestingly, the bit that's left in the ice are all the small molecules and water, and some of those small molecules are von Willebrand's factor cleaving protein. So what we would do is we would do plasma exchange, but we would use the icy bit, cryopore FFP. We used to take FFP, take the cryo off, and the bit that was left over at the end, we used to use because it had all of the von Willebrand's factor cleaving protein without those big molecules in. Now we just use normal FFP. So plasma exchange, aspirin over 50, never give platelets.
Is that aspirin for kids as well?
Everybody, yeah. And the point being is if you're worried about what's going to happen to their liver, when you've got 80% death rate, it just fades into insignificance. Yes. Yeah, and then as soon as their platelets cross 50, that's when you give it. And you give, that's their own platelets. You don't get their platelets above by giving them a transfusion. Does that make sense? Yeah. So yeah, just plasma exchange, and then, yeah. That's what it is. I'm having to go between two decks here, which is making it a bit inconvenient. And the last one on here is DIC. So we've talked about how this works. We've talked about how this works. How do you treat people with HELP? Magnesium is mostly used to get rid of and whatever the complications of organ failure. TTP and HUS, we've talked about how it works and what the treatment is, and now DIC. Yeah.
So when we have raised bilirubin and raised LDH,
Yep.
we're thinking about hemolysis,
Yes.
whether intravascular or extra.
Yes.
Just because we did the tape,
Yeah.
gave the impression that this is only for...
So no. The point is in the same way as when I had blood loss, and I put on there reticulocytosis, anemia, and those things, you don't only get that with just blood loss from bleeding. The idea is that as you move through that, you have number one. When you have extravascular, you have number 1 and 2. And when you have intravascular bad, you have number 1, number 2, and number 3. And so you decide saying, I know that I believe that I have extravascular hemolysis because my LDH is raised, my bilirubin is high, but my haptoglobin is entirely normal, and when I look at the urine, there's no blood in the urine. So therefore, I think that this is extravascular hemolysis. Now I've got to go to the causes. Do I think that this is a membrane, an enzyme, a hemoglobin problem? If it's not that, then is it a drug that's doing this? A sandy drug? Or is it an autoimmune cause? Now, in reality, people know whether they're one of those top 3. People know if they're hereditary sclerosis. It'll be in their notes as an adult. And the same with G6PD. And then the same with their sickle cell, you'll know. Drugs, as oxidative drugs, tends not to be. What it tends to be is autoimmune anemia, autoimmune hemolysis. And you've got to decide whether that's cold or warm, and we're going to come back to how you tell the difference between the two, but that is drugs or everything else.
Or if there's like any organ disease, basically. If there's like pancreatitis.
So if you've got pancreatitis, depending, I mean, you can end up with DIC with pancreatitis. So if you've got severe pancreatitis, you can just be a bit anemic when you are acutely unwell because your bone marrow turns off when you're acutely unwell. So that's why people, when they're anemic, the indices change a little bit and you ignore it when they're acutely unwell. But hemolysis, we're just, the diseases that add to that, we're just going through them one at a time just at the moment. Okay. So DIC, although the title is diffuse intravascular coagulation, the mechanism of death is bleeding to death. These people bleed to death. If you've ever seen anybody die of DIC, it is really horrible. Bleed to death.
You used to remember that death is coming.
Yeah. And ironically, you can spot DIC much earlier than people do, and when you spot it early, then death isn't coming. But the point being is that you see the hemoglobin going down, you see the platelets going down for 3 or 4 days with somebody with a horrible infective disease. Nobody's really done anything about it, and then they've got organ failure, and then it's very difficult to salvage. So people bleed to death, and how do they bleed to death? We go through a process of making a clot that we don't need, breaking down that clot because we don't need it. We've used up all of our clotting factor as we've made that clot, and then we make another clot, and we use up more of our factor 7, our factor 8, 9, 11, and 12, prothrombin and fibrinogen, until we make a clot, we break down a clot, we make a clot, we break down a clot, we're using materials to make these clots, we're using more materials to make these clots, we now no longer have any materials to make any new clots. And the places in my body where I need a clot, I can't make an appropriate clot, because I've wasted all of the material making clots that I don't need and breaking down clots that I don't need. So that's called a consumptive coagulopathy, because the reason that I have a pathology with my clotting is because I've consumed all of the goodies doing something that I shouldn't be. Sepsis causes this, massive trauma causes this, snake bites and venom causes this, cancers cause this, breaking open cells when I'm treating cancer so all of their guts come out into my circulation triggers DIC. So the cause of those are almost endless, but the severe unpleasant illnesses that cause it. But the point being is that what happens to my INR, if I've consumed all of my factor 7 until there is no more factor 7 left, it takes forever to make a clot, so my INR goes up. My APTTR goes up. What happens to my fibrinogen level? I've turned all of my fibrinogen level into fibrin and broken that down into D-dimers later. My fibrinogen level goes down. As soon as it goes down below what number am I very, very scared? 1. What happens to my platelets? Goes down. What happens to my hemoglobin? Goes down, because I'm making lots of these clots that when they are broken down, they turn into fibrin strands that then chop up red blood cells and consume my red blood cells as part of a microangiopathic hemolytic anemia. What happens to my D-dimers? My D-dimers increase. What happens to my bilirubin? Bilirubin goes up. What happens to my LDH? Goes up. What happens to my haptoglobin? Anything else I've forgotten that goes on that? Anybody can remember? Okay. So that's DIC. So now we've covered all of the different causes of microangiopathic hemolytic anemia. Management of DIC. Management of DIC is, what are you going to die of? Going to die of bleeding. What are the things that are low? Yeah. And so what I'm going to do is I'm going to replace the things that I'm low in. So I understand where you may in your head go, okay, well, with TTP and HUS, I wasn't giving platelets. because giving platelets was driving that underlying process. But in DIC, you've got to remember that in TTP and HUS, the singular and only pathology is making clots. And the making clot is causing damage to all of your organs. In DIC, the singular pathology is not the DIC. The singular pathology is the sickness that caused the DIC. So what you have to do is you've got to make sure that you don't die of bleeding from the DIC before you recover from the primary illness that is causing the DIC. So yes, in your head you could just go, well, I'm just going to drive more and more clots. Yes, but I'm not dying of the clots. I'm dying of the sepsis that's triggering the DIC, and me bleeding to death may be the thing that takes me out before I recover from my severe bilateral pneumonia with seeded. Does that answer your question? Okay. So what do you do? By the time your INR goes up and your APTT goes up, how much clotting factors have you got left? Less than, well, definitely less than 5, but most likely less than 1. So you don't want to wait until your INR and your APTTR goes up. The times that I spot it in clinical practice is I'm looking for this. And on almost all of the cases that I see of people with DIC, those start to go, but even before they're abnormal. I come in the first and coming on the first day and they've got a hemoglobin of 120, then it goes to 105. That happens with everyone because they've had some fluids. And their platelets have gone from 380 to 290 because they've had some fluids. But their U's are still high, and then I watch it and their hemoglobin is 105, 100, 92. And you think, well, is this person need a transfusion or not? But I'm more concerned about the fact that the platelets have also gone 290, 200, 170. And just because they're not below into the abnormal level, it's the trajectory of those two things together, as well as a high U score, that I then ask for a blood film. And then when I see the blood film and I can see they've got schistocytes, I can start making a plan that I need to aggressively manage this person, hit them very hard with fluids if they haven't already, escalate this person to intensive care or at least a high care area, make sure that they're monitored regularly, escalate their antibiotics so that they're on the best care possible, and get things ready should that evolve. And 9 times out of 10, that redirects them to a recovery before their INR has become abnormal. But the numbers of patients, I would see that then their APTTR is 1.4 and INR is 1.3, and then it's 1.5 the next day. And it's not catastrophically awful, but they're sat on and not aggressively managed enough. Is that okay? Understand that? Yep.
So in terms of replacing, let's say we want to replace the factors and the
Yep.
platelets, is there any serial like that we have to give the factors first?
No, it doesn't matter which you give them. You're just going to look at where is the threshold of lowness. People don't tend to bleed from low platelets before their platelets are less than 10, sometimes even less than 5. So you don't need to get too panicky about it if they're in the 20s to 30 region, even though you've got the number 50 in your head. The more of the point is that you see plenty of people with platelets of 11 and they clot perfectly fine. But you know once your INR and your APTTR goes up, you're down into the 1 to 2% left. And if you've already got rid of 98% and you're down to 1 to 2%, you haven't really got very much to play with. So the tendency is that FFP end is more important than that. And the more holes that they've got stuck in them, the more that you need to be wary of it, because that's where they'll bleed from. The more fragile their brain is, the more likely they are to have an intracranial hemorrhage. The worse their untreated gastritis is, the more likely they are to have an upper GI bleed. If they've got diverticular disease, the more likely they are to have a lower GI bleed. Everything that your body is battling against on a day-to-day basis to keep you afloat then falls apart. So your body is like, depending on how healthy you are, your body's like an old boat by the time you get into your 50s and 60s, where there's little packing tape stuck here, there, everywhere, an elastic band holding the lamp up. And when you get DIC, all of those bits of tape fall off and expose all of the underlying problems. If you're 17 years old and you don't play aggressive sports and you come in and you've got DIC, you're not likely to bleed from anywhere early because your body is fairly pristine. But you do have little bleeds everywhere, whether you realize it or not. Okay, moving into, going to come back and run in and fill in some of the gaps in bits and bobs a little bit later. But I would like to talk about your spleen and splenectomy before we finish the list for intravascular hemolysis. So we're going to come back to those in a second. I just don't want to overload your brain. We've talked about why you might take your spleen out. One of the reasons we said is if you had hereditary spherocytosis or hereditary elliptocytosis, you were born with that. I needed transfusions all of the time. It's inconvenient for your life. You're going to get iron overloaded eventually. Let's just take your spleen out and deal with the consequences. So one of the reasons might be I'm going to take it out because my spleen is too hungry. And it's eating my red blood cells. That's spheро and ellipto. My spleen could be a little bit hungry. I could have ITP. And that's where I have an immune process that's causing low platelets that are giving me a platelet-type bleeding pattern. The purpura is bleeding and having a petechial bleeding pattern on your skin. Ideally, I should stop my immune process, my antibodies, from beating up my platelets, taking steroids or immunosuppressants. But if I fail with medical therapy, I could just take my spleen out, and then my spleen will stop eating the platelets that have antibodies to them when they get stuck in the spleen. If my spleen is so enormous, it's squashing other organs, I can take it out. So you can end up with massive spleens from hematological malignancies. So from a rule of thumb, and you're going to come back to this a little bit later, this is the liver, this is the spleen. All hematological malignancies can give you hepatosplenomegaly, but myeloproliferative conditions tend to give you splenomegaly much worse than hepatomegaly. What are myeloproliferative conditions? We'll come back later if you don't know. And then lymphoproliferative conditions tend to give you hepatosplenomegaly, hepatomegaly more than splenomegaly. So myeloproliferative conditions are myelofibrosis, we'll come back to later. This is polycythemia rubra vera, essential thrombocytosis, chronic myeloid leukemia. All of these can give you enormous spleen, so big that it gives you hydronephrosis and bowel obstruction, and we take the spleen out because it's too big. Sometimes your spleen is suicidal, and it just kills itself. Things that cause a suicidal spleen, there's two. If you have sickle cell disease, you can block and infarct your spleen, and then when your spleen is infarcted, it can't do the job it's supposed to do anymore. And in celiac disease, you can get autoimmune destruction of the spleen. Anybody who has no spleen, if you do a blood film on them, you will see Hal Jolly bodies. So as soon as you see Hal Jolly bodies, if they've got no incision there, then it's because they've got either one of these two. Often you'll see that this is not evident. The most common in the Western world here is celiac disease. If they've got an incision, they probably had it removed, and then you need to work out why it was that they had that removed. But everybody who doesn't have a spleen should be treated in the same way. You need ABCs. You need daily penicillin. And you need to make sure you take all of your malaria prophylaxis. And that's including using nets, anything that you can as a barrier method, avoiding malaria endemic areas. Because without that spleen, if you pick up a low-grade malaria, those red blood cells aren't going to be picked off in your cord of Bullruth. So what would be a low-grade malaria for you and I with a low parasitemia? If you don't have a spleen picking those off, you can end up with massive parasitemias and very, very sick. ABC, well, what's that? Every 5 years, need to have your Hib, Haemophilus influenza B. You need your meningococcal C vaccine. And your pneumococcal A vaccine. So pneumococcal A vaccine, we just call them Pneumovax. Pneumococcal A vaccine, Haemophilus influenza B, meningococcus C, daily penicillin, malaria prophylaxis. So if you stumble across somebody and they've got Hal Jolly bodies there and you weren't aware about it before and they look fine, you don't just say, okay, well, you probably got celiac disease, it's okay. You need to make sure they are treated as being asplenic. If you are going to have your spleen taken out, you need to have these given 4 weeks before. Well, greater than 4 weeks before, but 4 weeks is a minimum. If I'm in a road traffic accident and my spleen is taken out because it needs to be and it's bleeding badly, then I must give this 2 weeks afterwards. Because the spleen is part of your immune system, if I give a vaccine closer than 4 weeks before an operation, then it just doesn't seem to work. It's not dangerous, but it just doesn't do the job. So, but if I'm taking it out as an elective, then I want good levels of protection against these more encapsulated bacteria, a higher risk of infection from. If I take it out, then I want the soonest that those vaccines tend to work is after 2 weeks. So I want protection as soon as possible after I've had an emergency splenectomy. Just because I can give it 2 weeks after an emergency splenectomy, especially in part 2, there'll be questions that trick you into. Somebody's coming in for an elective splenectomy. They haven't had their vaccines done 4 weeks before. The surgeon would like to go ahead with the operation. What's the most appropriate thing? And they'll be on there. Give vaccines 2 weeks afterwards. Cancel and reschedule the operation, etc., etc. And the answer is cancel and reschedule the operation. Not just give it 2 weeks afterwards because you couldn't be bothered to do it correctly the first time around. So 2 weeks after an emergency, 4 weeks before an elective. If you are a medical registrar, even though that's the guidelines, it will work 2 weeks before. So if the patient really needs it, if it's 2 weeks, it will still work. But guidance for exams, greater than 4 weeks, 2 weeks afterwards. Yeah. A sickle cell with celiac disease. Okay. Yep. Yeah, autosplenectomy, where your spleen has removed itself. Yeah.
Hoping that sickle cell is quite closely followed up, so they would have this. But either way, would you do a blood film and make starting this? You're not sure if they're on it.
Now, yeah, and the point being is that there are people who are followed up, there are people who are not, people who move around a lot. And on top of that, you can have somebody with sickle cell disease that the last time that they were seen, their spleen was working. And now they come into hospital, it's not working.
Okay,
It is worth checking to see whether it's, yeah. So we've got a couple of loose ends to wrap up from this, just a few, but we're going to stop now for a tea break. Is there any questions on what we've done so far? I will be filling in some gaps, but is there anything that I've discussed that just doesn't fit in your head? Okay, we'll stop for tea break.